Fetal growth restriction, new concepts. The ACOG calls fetal growth restriction as one of the most common and complex problems in obstetrics. We do know that fetal growth restriction is a common problem. The complexity of this problem has increased because of the numerous testing methods that we have now, and more importantly, because of our lack of ability to interpret these tests in an appropriate manner. Fetal growth restriction, we are all aware, causes short-term and long-term implications to the fetus, to the neonate, and also in adult life, and that is unquestioned. It's not a new concept anymore. The current challenges that we face in managing fetal growth restriction are accurate diagnosis of a truly growth restricted fetus, selecting the most appropriate fetal surveillance. Are there any interventions which actually prevent growth restriction, and are there any interventions that treat growth restriction when it's diagnosed, and how do you then optimize timing of delivery? I will use two case scenarios to do my best to complete addressing all these issues in the short time given to me. So coming to the accurate diagnosis of true growth restriction. A small fetus, we all know, is defined as a fetus which has failed to achieve its estimated weight threshold by a specific gestational age. So if you have a fetus which weighs less than the 10th centile for that gestational age, we know that this fetus is small for that gestational age. And the two crucial components that has been emphasized upon over here is that you need to establish an accurate gestational age, you need to establish accurate weight. Only then can you define the fetus as being small. And establishing accurate gestational age comes with doing an ultrasound biometry before 20 weeks, either a CRL prior to 14 weeks or a BPD from 14 to 20 weeks, and this is uncompromisable. This is what will establish your gestational age accurately, and nothing short of an ultrasound scan for determining the fetal weight. No other method will give us an accurate estimation of fetal weight. Now comes the third challenge, and this is actually more things that we face locally over here. You establish accurate gestational age, you establish accurate weight through a sophisticated sonography, but it's amalgamating and reporting this which forms the crux of the matter, and I will use this case study as an example of that. We have a 31-year-old second gravida who's booked at 6 weeks and 3 days. She has no significant medical history. However, in her first pregnancy, she was delivered at 32 weeks because oligohydramnios was found. She delivered a male child and the baby was admitted to an ICU. In this pregnancy, we did a scan at 8 weeks and established that her dates were corresponding to the gestational age, and her expected date of delivery was the 27th of October. She had a nuchal scan subsequently confirming the dates, and she had her mid-trimester anomaly scan, and then she came back with a scan done at 30 weeks, which was reported like this. It showed that the estimated fetal age by ultrasound was 27 weeks and 2 days. She was 30 weeks at this point of time, and the expected date of delivery by ultrasound was given as 22nd September. So do we accept a report like this? Here you have a woman in whom you have established dates, and with no uncertain means you have done 2 ultrasound scans and you have established her expected date of delivery is in the last week of October, and then you have a 3rd trimester scan which suddenly changes her expected date of delivery, and that is completely unacceptable. So this expected date of delivery, do not redate pregnancy by a 3rd trimester scan. Once you establish the expected date of delivery by your 1st trimester scan, don't change it. Any variation in biometry after that, when you do in the 3rd trimester, if your parameters are corresponding to 27 weeks when the woman is 30 weeks gestation, it simply means that she has a growth problem. So you need to demand better reporting of the ultrasound reports. So we need to know, when you look at a report which comes, the 3rd trimester report, you need to know whether it is a growth problem. If it is a growth problem, how severe it is. And this can happen only with the use of growth charts. customized growth charts which are very easily available now. There are a number of softwares right now which are customized to Indian population, and you should insist that your sonologists who are doing your scans for you regularly should treat obstetric sonology as a separate discipline, and they have to invest in customized growth charts. And this is how the reporting then occurs. A customized growth chart actually amalgamates all the previous ultrasound reports. If you can see over here, it does the entire examination dates and establishes dates, comes back to you and tells you exactly where the fetal growth is, 1372 grams, which lies on the 5th centile, what is the amniotic fluid, and how are the Dopplers. So it gives you growth charts which you can look at, eyeball, and determine where this baby is. If you simply have a weight given to you, and if you have biometric parameters which are once again redating the pregnancy, that's not an acceptable scan. So it's very important to use customized growth scans if we want to interpret growth restriction. And this is the reason why most unexplained stillbirths occur, because we are not diagnosing growth problems appropriately. So now you have a diagnosis, you have the growth on the 5th centile, you know that this baby is small. Now the next step is, what should we know now? Is this baby just a small for gestational age baby, that is, it's constitutionally small and otherwise healthy, or is it growth restricted? And to determine this, you have your biometry, which is the weight, and you know that the weight is small. Now you want to know whether this baby has some pathologic process which is causing the baby to be small. That is this baby small because the baby is starved of nutrients, or is this baby small because it's constitutionally, genetically predetermined to be small, which is coming from, a lot of inherited factors. And the most appropriate surveillance tool is the umbilical artery Doppler. So if you have a normal umbilical artery Doppler and you have a small baby, this means that this is a physiologically small baby. If you have an abnormal umbilical artery Doppler and you have a small baby, this is a growth restricted baby. So true growth restriction is established only with an umbilical artery Doppler, and there is absolutely no substitute for that. So the take home messages from this case are, dating of pregnancy and establishing expected date should happen in the first trimester or before 20 weeks, and that's absolutely crucial. Do not redate pregnancy after that. Any discrepancies after that should make us suspect growth disorders. We as obstetricians should insist on the use of growth charts and growth curves for reporting growth scans. And when Doppler studies and fetal movements are normal, these babies can in fact be delivered at term. Then comes the second case. Here we had a lady who was 34 years old, married for 12 years. She has had 3 previous pregnancy losses. She's a known case of bicoordinate uterus, hypothyroid, and she booked for antenatal care with us at 24 weeks and 2 days. Her course of pregnancy until she came to us, she had previous regular cycles. She had a normal nuchal scan, but her mid-trimester anomaly scan showed that both uterine arteries had a high resistance flow with bilateral notching. So what is the role of uterine artery Doppler in cases of growth restriction? Uterine artery Doppler evaluation in the 2nd or 1st trimester has been proposed as a screening tool for early onset growth restriction. It has detection rates of about 75% when used in the 2nd trimester and 25% when used in the 1st trimester, but it does have a false positive rate. And it showed that when you treated such women with aspirin, there was a 20% reduction in the incidence of preeclampsia. Remember, it's preeclampsia and not growth restriction. So what is the evidence for the present interventions to prevent growth restriction? If you find a woman at high risk, what interventions could you use? Can you use aspirin? Antiplatelet agents can be effective in preventing an SGA birth in high risk women, and they should be commenced before 16 weeks of pregnancy. And this is what makes the case for doing uterine artery Doppler in the 1st trimester, because if you do it at 20 weeks, even if you want to use an interventional method which comes with some evidence, you may be too late for it. Maternal nutrient supplementation, progesterone and calcium do not prevent SGA birth, and they should not be used for this indication. Interventions to promote smoking cessation may prevent SGA birth. And so if you do have women who smoke, I think that's one of the most effective methods. What about using biochemical markers? There's an upsurge of using PAP-A to predict small for gestational age fetuses, and what is the evidence that we have? There is an association with growth restriction and preeclampsia, but the specificity and sensitivity and predictive values of these markers either individually or combined does not support their routine use. So they should not be used for these purposes. And there are no clear-cut benefits of any intensive surveillance or prophylactic strategies in this group of women. So they should right now be restricted for what they've been meant to do, and that is for diagnosing aneuploidies. So this woman came to us, and at 24 weeks and 5 days, she had a baby which was below the 5th centile and had a normal amniotic fluid volume. So this was a small for gestational age fetus at very early gestation, at 24 weeks and 5 days. So, and we wanted to now make this difference, and we introduced the umbilical artery Doppler, which showed a high resistance flow. So basically this was a truly growth restricted fetus and not just a small for gestational age fetus, but remember this is at a very early gestational age. So what are the management options we have for these women, and then what is the evidence for these management options? Obviously counseling plays a huge role over here, because at 24 weeks and 5 days you have diagnosed growth restriction in a woman who's 34 years with 3 previous pregnancy losses. Is there any role for doing karyotyping? Karyotyping should be offered only in severely growth restricted fetuses if there is no problem with uterine artery Doppler. If the uterine artery Doppler is normal, then you're thinking of chromosomal problems at that point of time. Then infection screens also should be offered with severe SGA. So in this woman, we did not do a karyotyping. Her infection screen was normal, and then how would we then follow up? What interventions, if any, exist to treat fetal growth restriction? What is the evidence? IV fluids, IV amino acids, bed rest, no use. Absolutely no evidence for any of these things for treating growth restriction. The only evidence we have is intense fetal surveillance and timely delivery continue to remain the main strategy for management of truly growth restricted fetuses. What about steroids at this gestational age? Again, there is no data to support giving steroids before 26 weeks of gestation. And what is the purpose of this intense surveillance that we have to place these fetuses under? Basically, at this point, we want as much maturity as possible with as little fetal hypoxia as possible. And this is an extremely difficult balance to strike. So you want to avoid fetal hypoxia and gain as much maturity, as much intrauterine life for this fetus as possible. So what would be your strategies for doing this intense fetal surveillance? And again, what is the evidence for biophysical profile, Dopplers, and cardiotocography? Biophysical profile, as you know, was introduced in 1984, and it has so many components to it. But by the end of the day, the biophysical profile is only an indirect evidence of intact perfusion. You're looking at parameters like breathing movements, movements of the baby, and then you're interpreting them and saying that if this is there, probably the baby is getting enough blood flow. But Doppler flow studies are direct evidence of perfusion. They are less time consuming, they are more reproducible, more objective, and definitely more standardized. So which Doppler would you use, and what is the rationale of using Dopplers? So this is to recap. You have abnormal biometrics, you have abnormal biophysics in this woman. To interpret Doppler flow is crucial to achieving this balance between maturity and fetal hypoxia. And the Truffle study has come up with a lot of insight into this. And before we even proceed with how to interpret Dopplers, I think we should understand what fetal circulation is all about. If you can see, we have two umbilical arteries and an umbilical vein. The vein carries oxygenated blood and it passes through the ductus venosus, and then you have bypasses in the fetal circulation because the lungs are not being used for oxygenation of the blood. And then the deoxygenated blood is returned to the placenta through the two umbilical arteries. So the umbilical artery Doppler, which we are actually doing, which panics, excites us, and urges us to deliver the baby, is simply measuring what resistance is there in the placental bed. It doesn't do anything more than that. When the umbilical artery resistance is high, all it is telling us is that the placental bed has a high resistance to, taking back the blood flow. And it has been chosen because it's a very accessible blood vessel, and that's the reason we have studied the umbilical artery. So if there is resistance in the placental circulation, you will find that the umbilical artery blood flow, the resistance goes up, then there will be an absence in the end-diastolic flow, and then there will be a reversal in the diastolic flow. So these are the categories of abnormalities that the umbilical artery Doppler goes through: increased impedance, and this is used with the pulsatility index, absent end-diastolic flow, and reversed end-diastolic flow. So if there is an increase in placental resistance, does that automatically mean that the fetus is hypoxic? And the answer to that is a no. The placenta simply supplies oxygenated blood to the fetus. If that starts reducing, what does the fetus do? It starts compensating internally. It redistributes its blood flow. It increases the blood to the brain, heart, and adrenals, and this is called the brain sparing effect, and reduces it to the kidney, gut, and lower extremities. And this is exactly how a human responds to, any form of exsanguination or hypoxia is. We start compensating, and that's what the fetus does. So the umbilical vessels study perfusion of placental circulation, whereas the fetal vessels actually study the fetal circulation. So if you have an abnormal placental circulation, the next step you should see is to say whether this fetus is compensating and is it well oxygenated or not. So your umbilical artery Doppler is not the single determining factor towards delivery. If you have an abnormal umbilical artery Doppler, it means you should go looking at the fetus and seeing, is this a well compensated fetus? And the two vessels which tell you whether the fetus is well compensated is your middle cerebral arteries and ductus venosus. So the middle cerebral artery tells you whether there is a brain sparing effect, and this is reflected by a low PI in the middle cerebral arteries. Alternatively, you could use what is called a cerebroplacental ratio. And then comes the venous blood flow. When you have venous blood flow abnormalities, it means that there is a lot of back pressure. The placental resistance is so high that there is the ventricular end diastolic pressure is increasing, and there is lot of back pressure occurring, which is leading to hypoxia. So your venous blood redistribution, when it starts occurring, when there is a normal venous Doppler, you have continuing fetal compensation. But when the venous Doppler becomes abnormal, this indicates a breakdown of all compensatory mechanisms, and it's time to deliver. And these Dopplers are especially important when you see early onset growth restriction, because this is the time when you want to buy time. You don't want to advise them that there is no hope and they have to terminate pregnancies, but it's crucial that you need to get up to a time when salvageability is high, and the more time you can get out of the fetus and leave it well oxygenated, the better will be your outcomes, because most growth restricted fetuses, the outcomes are confounded by the prematurity, by the gestational age at which you deliver them. So when we assessed this lady at 28 weeks, because after 24 weeks we had a detailed discussion with the family, and we said that if something goes wrong also we won't be able to do much, so it would be reasonable to re-evaluate again at 26 to 28 weeks. We found at that point of time that the baby was on the 5th centile, there was absent end diastolic flow, whereas the MCA and DV were normal. And at this point we decided to wait. So absent end diastolic flow is not an indication for delivery as long as your middle cerebral artery Dopplers and your ductus venosus Dopplers are normal, but it's a red flag sign where it's time you should start thinking of steroids, and you have to start discussing with the family that every day you get out of them will be a time where you'll be discussing delivery. You have to intensify surveillance. This lady later developed hypertension. She had MCA redistribution and the weight remained static. And she had intense inpatient surveillance at that point of time with detailed neonatal counseling which was done. At 31 weeks and 2 days, her blood pressure became further higher, and we didn't find any further improvement either in the weight of the baby or in the Dopplers, and since the maternal condition was worsening, we decided to deliver this baby. Now the advantage of interpreting your Dopplers right is that You can monitor even an absent end diastolic flow and gain additional time in the extremely premature babies. So interpreting Dopplers is really crucial, and that is the only tool which is of any value in the surveillance of the small for gestational age babies, both diagnostically and for prognosticating. So if you have an abnormal Doppler with an SGA fetus, you have a truly growth restricted fetus. And then as this umbilical artery Doppler becomes abnormal, depending on the gestational age, you will decide whether you want to recruit the other Dopplers to help you postpone pregnancy while maintaining the fetus in a well oxygenated state. So in summary, when you have early onset growth restriction, if it happens between 24 to 28 weeks and you have an abnormal Doppler, you discuss with the family and defer monitoring. If it happens between 28 to 32 weeks, if you have arrested fetal growth and abnormal venous Dopplers, it's time to deliver. You don't act only on umbilical artery Doppler. But at 32 to 34 weeks, the baby is more mature, you know that salvageability is higher. So if you have arrested growth and you have abnormal umbilical artery Dopplers, then it's time for steroids and delivery. And thank you very much. That concludes my talk.